Perfect. So we will call the meeting to order at 10 o'clock and I will turn it over to Calista for the.
Okay, thank you. Chad Richards,
I'm here.
Shirley Keaveney,
Present, thank you.
Andrea Machasovs, Kenneth Craig,
Present.
Don Murray,
Present.
Jay Kirkland,
Present.
Beverly Wilkins,
Present.
Helen Claire Tingling,
I am here with apologies for my camera not working.
Saunders, Nick Saunders, Sue Carlton, Kevin Eccles. Okay.
Perfect. Thanks very much, Calista. All right, we'll move on to item 3.0. We have a couple of amendments to the agenda that I would like to share, but before we do that, does anybody have any amendments to the agenda that they wanted to raise at this time? Does.
Yeah, just,
Yeah.
I do have to be back for a couple of grand openings by 3 o'clock, so
Okay, yeah.
we can get out of there.
Thanks, right, nice and efficient.
Thank you.
Perfect. So just on the amendments to the agenda from our side of things here, we would like to move item 8.6 into the staff presentations section, so 10.0 of our agenda today, just to have that item covered in the staff presentations, and we have staff who can share information about that. And in addition to that amendment, we would also like to add one item in our in-camera agenda about adoption of personal matters about unidentifiable individuals, just adding in addition. With those amendments, I would look for a motion to adopt the agenda as amended. Moved by Bev, seconded by Don. Any discussion on that motion? Seeing none, all in favor? That is carried. Perfect. At this time, I would ask if any members of the board have must disclose any pecuniary interest. If none, which is certainly can inform if one arises for the hearing. Perfect. On to item 6.0. For a mover and seconder, that the minutes from Friday, April 25th, 2025 be approved by the Board of Health as presented. A mover and a seconder for that. Moved by Shirley, seconded by Jay. Any discussion on the minutes from our April 25th meeting? Seeing none, perfect. I'll call the vote on that motion then. The minutes be adopted. All in favor? That is great. Perfect. All right, moving right along to correspondence and media releases. I'll turn it over to
Thank you, Mr. Chair. It's review. There are 6 media releases on this month's agenda, including a May 14th media release related to a potential rabies exposure investigation. And the remaining media releases relate to the ongoing measles situation occurring locally and provincially. Now, May 9th, Public Health issued a media release to announce that Ontario's Chief Medical Officer of Health is recommending families in Southwestern Ontario, including in Grey Bruce, seek earlier measles vaccination for babies and children under 5. This is due to the increased risk of measles exposure in Western Ontario. And the remaining 4 media releases were issued in response to potential measles exposures in Grey Bruce. So after Public Health receives notification of a measles case in Grey Bruce, it undertakes a case and contact tracing investigation. And if the investigation reveals the case visited a public space when they were potentially infectious, and Public Health is unable to identify and contact each person who attended that space within the exposure window, a media release is issued to inform the public of the potential measles exposure. So the media release also contains steps individuals should take if they were present at the location during the exposure window. And that concludes the media release.
discussion in the board or questions for any releases. Seeing none. I will then look for a mover and a seconder for the motion that the media releases be received by the Board of Health for information. Except for that. Moved by Andrea, seconded by Doug. All in favor? It was carried. Perfect. On to item 8.0, the medical officer talk update. What do we do? Question update. Do you have any questions? No coordination to correspond. Perfect. Great. That was confusing. Perfect. So great. Right along to the medical officer talk update. Dr.
Thank you, Mr. Chair. We have a number of updates. The first one of them is related to the opioid situation in Great Bruce, and I will provide an update, and at the very end, there is a proposal for a resolution to the 25 Alpha Annual General Meeting that the board can decide to do or not. But the update is related to impact statement that provided from our health unit under the leadership of the current chair, Mr. Nick Saunders. He had worked obviously with the indigenous community, we worked with the OPP, and he saw the opportunity of supporting the judicial system or the OPP specifically in ensuring impact statement of the opioid crisis on the communities in Great Bruce in general and the indigenous community is delivered in a way that would be most helpful for the system to see the actual impact. And as a result, there was, as included in the package, outlined nicely in the Sun-Times article, the entire process that happened related to a court case and laying charges to drug distributors, and we're talking about mid and high level drug distributors, not the regular person on the street using drugs and being a victim of the drugs, more or less. So there was a warning in the hearing or in the conclusion of that case from the court, warning to people who sell drugs not to come to Great Bruce because there will be higher penalties. Every 10 years, it's the highest, according to the article, number that can be given. So it's a deterrent for distribution of drugs. And public health has always had the enforcement aspect of its work. We have education, we have healthcare, and all these systems are doing good work. The enforcement is an opportunity to support other systems, the enforcement of police agencies and what they do. So that was a success. And the chair is suggested if we take this to the Alpha meeting, and for the people who are not around the table, Alpha is the Association of Public Health Agencies. It's an arm's length from the government. It's not a government organization. It's an association of all boards of health and health units. And they usually lay down the strategic direction for public health in Ontario and advocate for the government, the different levels of government to advance good causes. So the suggestion from the chair is the board agrees to put a resolution to Alpha to say, we wanted to ensure health units can contribute in this work and hopefully down the road can be included in the standards for health units to be part of our mandate. You look at the case, business case for it, it's very attractive because the cost of it is literally our pens to write an impact statement. We have the data, we have the ability to produce these reports, and it has been of service to other parts of the establishment, the system, I mean the judicial system or the enforcement agencies. And that's one thing that we can help in. We can augment communication to support the enforcement agencies. And there could be other things. I didn't draft the resolution itself, so I wouldn't narrow down what we can suggest to Alpha. And if there is a discussion around this table now or in the coming few weeks, we can include those suggestions that would come from the board. To be complete, our board sent a resolution to Alpha last year to support the indigenous communities in improving the health services provided on reserves. And that resolution was passed unanimously. The chair at the time, he was not the chair, but he spoke to the group in Alpha, and that passed as part of the strategic plan for Alpha. So this resolution can be a subset of that one as well. I will open to questions or direction on the matter.
Excellent. Any discussion or questions for Dr. Ara, that portion of the medical default update? Tom?
And I guess I agree with lots of Nick's comments here, but I would like to see it be the same for everybody in the Grey Bruce area. Because his comments are very true, how it splits up the First Nations communities. But it is doing the very same in our communities, so I want to make sure we're treating everybody the same when we put comments forward. That we're open to everybody in the Grey Bruce medical officer health right or area. So I know it's kind of there, but I just want to make sure that we're all on the same page or same level going forward.
Certainly, Dr.
Yeah, certainly, most certainly. This document was produced by the health committee, co-signed by the chair and myself. And it reflects the situation in the indigenous community because that was a request from the prosecution or from the OPP, because that's their case. Nevertheless, the less distribution will help the entire communities. And you're correct in a way that if this becomes part of our business going forward, it will be based on the request from the OPP or the police agencies for different, whether it's Hanover or Sound or any, and we can describe the situation in each community based on the data that.
Yes, to the chair. I think it's really quite encouraging. I'm on the food services board just in Old Town. And they are very buoyed, as one would say, in the true sense of it, with the BOUY, in the fact that finally someone has heard the case and there is a punitive portion. Now they're asking that they therefore be empowered in some way. How are we therefore going to support this? And I think therefore the onus is then upon various groups in our communities to do a letter of support with it. So I know that will be coming. We add on to what has been a great initiative. And that's what you asked.
Discussion from board? Just on the resolution process for Alpha, what kind of things next in the process here?
If the board is supported, the staff can proceed with submitting the resolution. It's a late resolution. The deadline for submitting them is in March, but there is a process to accept late resolutions, and there's no way to have proceeded with this before the court finished their work and the results come out, and we'll keep the board updated with the process.
That sounds like, okay.
Will we see the final resolution, or it has to come to the board for the next meeting to be voted on, or will it be sent out before?
Through you, Mr. Chair, excellent question, and I neglected to mention, we need probably to do it by email, so we'll send it to the board by email and people can comment on it, just in the interest of time. The meeting for Alpha is in June, and the request that any late resolution comes as soon as possible. So we have to do it by email, and yes, the board will be appraised of it, and not just appraised, approved, has input in it and approve it by email.
Are we, I just, in procedure, are we allowed to do that by email to come up with a vote of the board prior, or do we have to call a meeting? Even if it is by email, do we have to call a meeting to be able to give you direction? I'm okay with what you're doing if you're allowed to do that. That's all I'm.
Through you, Mr. Chair, any email that carries everybody's on the board is actually public document, part of the board business, and that can be done.
Okay, I know we couldn't do it as a council from South Bruce Peninsula. We would have to advertise a meeting to be able to give direction. Unless we give direction today for you to be able to put a press release out with 2 or 3 of the points that have been made, and then you can, and then if nobody has a problem with your press release, they will not respond on the email. Like if we read it I don't know if you know what I'm meaning. I just hate to give you direction over email if it's not proper, like,
I think so what Dr. R is looking for today is general direction, just have to proceed with a draft resolution. That draft resolution would then be shared via email with the board and similar process to what you've outlined.
Okay.
If nobody has any exceptions with it, then I never response. Was that management correctly?
Correct, and I see Jay's point that if there is comment and voting on it, we would have to advertise it as another meeting. So
that's all I mean.
yeah.
I don't want to be a stickler, but
No.
we've got not caught, but, things didn't get to move forward because of situations where.
If there is direction in this meeting, that would eliminate that possibility.
Right.
So directed.
I think that's very appropriate, Mr. Chair, because that would be seen as advancing the business of the board outside of formal meetings, so. In my mind, we want to be cautious of that, that's just how we're trained to,
That direction is being given here today through this discussion, so.
Yep.
Any other discussion from any board members? Not seeing any. Dr. R, you have your lead from on that item?
Yes, I do, Sir Chair, thank you.
Perfect. You continue ahead.
The second item is strengthening public health, and it has been a standing item for 2 years, and there were a number of good updates on the process. My recommendation to the board is to discontinue this item, but that process more or less is really. Last update we received that they are complete and they will be released in August, and will be in effect in January, the public health standards for Ontario. So there are no new updates, and I don't expect any new updates going forward. So with the board's permission, we can discontinue it. And the next item is client satisfaction survey. We do a number of continuous quality improvement, and one of them is survey on feedback that we receive from the public. We receive it in different formats directly to the team, to the managers, and one of them is to data that comes to the website, and we collate this data, bring it to the board once a year, but sometimes we bring it earlier if there is any issue. Last year, there were a number of updates, so or there were one update mid-year. So it was included in this as well. So this could be a repeat for some people. And probably this page number 3 would clearly the need of the report. 80% of the respondents, 82% were strongly agreed that the staff acknowledged and explained. People are happy with our services. There are around between 10 to 15, depending. Strongly disagree or not agree, and that was related to the vaccine distribution. That was what was brought to the board last year. We always address the issues immediately through the managers, then it will make it to this report. So when it made it to this report last year, and obviously now that's already been addressed, the changes that made in the program to ensure that there is staff available to provide the necessary service in the small number of people who requested that. So all in all, it reflects good results. Like 80% of the public is happy, and the 10% or 15% partially disagree. And the ones who are strongly disagree, we followed up with to ensure that everybody is satisfied. It's worth looking at the stats as well. Related to, sorry, I'm trying to, who called us? Yeah, it's a group of people from all ages, which is great. Our clients mainly are between 40 and 80 years old, the calls, but we got a call as early as 9 years old calling and we responded. The calls are from both counties, from different age groups, as I mentioned, from. The sample is very, representative of the population, and any sample over 20, it has enough leverage or power to convey that 81 responses. We had way more than that through the programs, but that's not the survey. Open to questions as always.
Just, I'm always striving for 100%. I know you never get there, but you always try to do that, and staff always do that. When you, in another year from now, when you bring this graph back for how we did this year, can you include the last year on this graph?
Certainly.
Just so that we can compare to how we did from last year to this year. And it's nice to see, there might be a specific area where the board feels that we need to be stronger in. It's nice to see how we did from last year to compare how we're doing.
Mr. Chair, I always enjoy Jay's questions because this is the first year we do it after the pandemic. During the pandemic, we had
A little bit crazy.
So we had it in 2019 before the pandemic. Then during the pandemic, the number of people were calling us and you need service provided immediately. So we opened phone lines. So most of our input was through the phone system. And after the pandemic, we put together the process again and it started last year.
So this is, okay,
And this is the first complete survey.
thank you.
Mr. Chair, thank you. And a question to Dr. if I may. I'm curious to know, do all health units do this type of survey? And if so, where do we stand in comparison to other units?
Mr. Chair, the standards from Ontario requires each health unit to do it. I can't speak to know if every one of them does it, but many of them do. This is an excellent result. This is as good as it gets. And when you look at the comments specifically, there is nothing that is red flag. I was, whatever is a complaint that could be serious. It's I showed up in the health unit. I had to wait for this long to see somebody because there wasn't somebody ready for this type of advice. So we designed 2 individuals to be at all times receiving calls from the public and available in person. It's this type of process. All in all, I'm very proud of these results. Very proud.
Good to hear. Congratulations.
Thank you.
Any other discussion? Okay. Make sure I'm not seeing anybody online. Sure. Thanks, Dr. Would you continue on?
Thank you. The next item is safe food and water. That's with the Andy.
Thank you, Dr. and for you, Mr. Chair. So the first report we have here is an overview of Great Bruce Public Health safe food and water programs. It's our recommendation that the Board of Health receive for information this report, which provides an overview of those 2 programs. Now, the key points that are noted in the report is that Great Bruce Public Health plans, develops and provides the local components of a food safety network with a focus on food safety inspections and complaint response to reduce the burden of disease. Safe water program, similarly, the program focuses on preventing and reducing waterborne illness and reducing recreational water injuries through inspections, assessments and advice. So both programs support the health of residents and of course visitors to Grey and Bruce counties and continue to strive to further reduce the burden of disease and injury. Some additional notes that I will just bring forward as well. 4 of the programs that we're looking at this morning are some of the environmental health programs. The environmental health team consists of 12 public health inspectors and 2 program assistants. Public health helps to reduce and prevent infectious diseases caused by the consumption of contaminated food and water and reduces the burden of injuries through physical, chemical and electrical hazards. So Health Canada estimates that about 1 in 8 Canadians get food poisoning every year, to give a sense of the scale of the issue. And additionally, the scale of things. So in 2024, Grey Bruce was home to nearly 1,800 food premises. PHI has conducted nearly 1,900 food safety inspections, investigated 98 complaints. We responded to 84 adverse water quality incidents, and that is both the systems that we regulate as well as the Ministry of Environment regulation systems. Conducted 116 inspections at small drinking water systems. And additionally, residents of Grey Bruce took over 10,000 private water samples through the support of our courier system. And we actually, as we were just speaking about, maintain a 5-day-a-week helpline system so that if residents wish to connect with us, we can give advice about those results, as well as any other inquiries on environmental health matters. And then finally, public health inspectors conducted 352 inspections at recreational water facilities. So this is pools, public spas, that kind of thing. So to conclude, safe food and water supplies are essential to our well-being, and ongoing efforts to ensure that food and water is of high quality. Both programs support the health of residents and visitors. And we continue to strive to reduce the burden of disease and injury.
Discussion or questions for?
And this is the beaches and Sauble Beach is one of those beaches. Do we offer this service to our First Nations?
So beaches specifically?
Yes.
So the beaches that we sample at are defined by the standards, the current standards. And they're fairly restricted in terms of where we do sample at. So they are municipally owned, so it's not the First Nation beaches. It's also not the provincial or national parks, so that they do have their own testing programs there. It's not all municipal. I mean, obviously there's a lot of access to water across Grey Bruce, so it's not every place where you can access water, but it is the sort of more, I guess, well-known public beaches. So, typically if you've got somewhere, if you've got perhaps playground facilities, washrooms, parking, and it's everyone would recognize it as a beach. It's those sort of locations.
I just use Sauble Beach as an example because of the large influx of tourists, and it's in my municipality. And when I'm wondering why we don't offer the service or do the service when we have like our nation, First Nation, on the board.
Yeah.
And why, when there's a line in the sand that on this side we could have an adverse water quality, but on this side we don't.
Yeah.
And I look at, in general, for the public, the health of the public. So, you can't put a sign up over here, but you can put a sign up over here. And that, to me, is not what we're trying to do for public health.
Right.
It's my own opinion.
Yeah. So my understanding is that First Nation do their own sampling. And when there were some recent changes on that particular location, we did actually offer as well.
Oh, okay. So we did. Okay. That was my question.
Yeah.
Yep. All right.
Claire, you go ahead.
Yes, thank you, Mr. Chair, through you. Just wondering, thanks for the presentation, but just wondering if private well water testing compliance is tracked. We heard that 10,000 samples went through, and I'm just wondering how does that relate to the absolute number of private wells we have in our catchment area, and whether or not we're tracking compliance. Are there people with private wells that aren't getting their well water tested? And what can we do about that if that's the case? Hope that's clear. Thank you.
Yeah, it is. I think there's a few really important points there. So, yes, it's tracked. There's a municipal, provincially maintained database that we have access to that shows, those numbers and the numbers that maybe either in some way the sampling went wrong and those that were actually adverse samples as well. So we do have access to that data. There's a number of agencies, and probably the most recent, most important report of this is the Office of the Auditor General report, came out earlier this year, that have noted that the testing of private wells is it's less than it should be. They are, as a general across the province, under tested. And that the number of wells that are being tested is steadily on the decline. Ours have held relatively static at a little over 10,000 for about the last 5 years. but it is definitely a decline on where we were perhaps 15, 20 years ago. And generally across the province, there's been quite a significant decline in the number of tests that the public have taken. Are all wells being tested? I can for a fact say that they are not, just based off the numbers. We know that we have, more wells than are being tested. Now, of course, they're not regulated. These are people's own wells. So it's difficult to know exactly which ones are or aren't tested. But overall, as an answer to that question, I would say I think it's fair to typify it as being under tested. So then for the question about what are we doing about it? So certainly with our communications department, we do media releases, encouraging people to test. We do have some paid advertising in some sort of key areas that are focused more on farming communities. We have in the past done some other media, TV and radio and things as well. And of course, the website. So we have done a number of things over the years to try and encourage testing, but certainly it is an area that I think we need to continue to focus on. The courier system that Grey Bruce Public Health has introduced, which is, if not unique, certainly very rare across health units, was really part of that process. So we have 14 locations where we would have only had 2 for the Public Health Ontario pickup points. And that was in an attempt to remove or reduce one of the barriers, so the barrier of accessibility and how close you are to those drop-off points. So we are certainly active and have come up with some, I would say, fairly innovative solutions, but more progress really would be ideal. I think, I would like to see that number going up rather than declining.
Yeah, just to build on what Andy mentioned, we have a mandate, the health unit has a mandate of testing small drinking water system and working with the operators. And that's different from private homes or private wells. There are 433 small drinking water system active in Grey Bruce. All of them are covered, followed by our team. The private ones, the difference between small drinking water system and private is minor but complex. Any private well, if they, for example, a farmhouse, if they turn it into a B&B, now the public has access to it, it becomes small drinking water system. Anything that the public has access to is for us to manage. The private, we're not. Back to the question, specifically 10,000 tests. This is, a number that might not really convey the actual happening. There was a lady who tested her private well almost daily. And that generates a huge number of tests. The total rate is less than optimal, and that's across the province. And it's worth mentioning to people who are listening to us, and I have a presentation on drinking water and the package in the anniversary of the 25th anniversary of Walkington. It's worth for people who are listening to, during the pandemic, the number of pickup or drop-off of test samples decreased because of the policies that happened during the pandemic. Many hospitals said, we don't want the public to come to the hospital unless there is a very serious condition. Many of these testing pickup and drop-off centers were in hospitals. So Grey Bruce went down to, I think, 1 or 2, and it was through the management of grocery stores. So we partnered up with grocery stores, essential services, where people can pick up these samples. Also worth mentioning, it's not our mandate. That's a provincial program to provide publicly funded testing. We managed locally to ensure this continues. After the pandemic, many of the organizations that used to pick up the samples decided that's not for us. So the health unit went out of its way 2 years ago to design a specific program, and we have our own courier. We hired them to pick up samples from 14 locations. We work with municipalities to ensure that there is access within Grey Goose. Can't exactly remember the number, whether it's 25 minutes or 15 minutes, the drive from anybody in Grey Goose to drop off their sample. We had a campaign, paid advertisement. Unfortunately, with all that effort, the rate is still less than optimal. And part of the presentation today is to raise awareness. The media is listening. If there are a couple of articles, and we put our media releases, especially in the spring when the testing is appropriate. I delivered half my presentation now in this. I'm sure if there's more on the session.
Just a quick question. Do we have the right, and typically there's one water table within a certain area that everybody's drawing from that aquifer. Do we have the right to designate a press release for a specific area? If we get one or two bad tests in a certain 5 mile area, do we have the right to tell the rest of the people in that area, you better get your, or you could be getting your water tested? Because we've had 2 or 3 adverse qualities in your area, or don't do specific, we try to keep it broad, because once you, if you named, I'll say Hepworth, in the Hepworth area in a press release, I think you're gonna spark a lot more interest for people with private wells to get the well checked if there's been an adverse quality of well water, private well water in that area. And it shouldn't be specific to a town, I don't mean to do that, but can we do that?
Through you, Mr. Chair, and Andy can build more on what I'm gonna say. Technically, the distance from a well and the contamination is very limited, and it would be for the well itself. There will be many barriers to identifying an area, and one of them is what you just mentioned, to stigmatize that area, and suddenly the property value goes down and people go up in arms. And technically, there isn't evidence that the contamination spreads through that distance. It's local to the well itself, and there are many factors that comes in the risk assessment. So I'll turn that part to Andy.
Yeah, no, that's exactly it. So whilst technically you can have contamination of an aquifer, the reality is the majority, if not all the cases we see, are not that. So this is much more localized. You could have 2 neighbors, one with a dug well, one with a correctly designed and maintained drilled well, and the results will be completely different from each other, even though they are within a few feet of each other. The final part of the answer I would say, though, is that there are occasions where we do that. So actually last year we had an incident where there was a significant impact to a well, both from Ministry of Environment as well as us were involved with this one. And there was localized geology, so karst limestone in this area, that gave us sufficient concern that it might impact more than that one well, which is more typically what happens. So in that case, we actually went, both of us and the Ministry of Environment went door to door for the neighbours where, within a geographic area that we thought may have been impacted. That's relatively unusual, but certainly if there is evidence that it might be impacting more than one home, then we would do that.
So we have done that before. Okay, that answers my question.
Yeah.
And I was just gonna say, it's one of our greatest resources. In our municipality, we have a mandatory septic inspection program right across our municipality. And I've said for years, I think we should be very proud of those. Because everybody treats them different, and it's very concerning. It's we can't live without it, so. And my other question is, when there is a case of E. coli, do you follow up? Like, we have a young lad in our municipality that's been in hospital for over a month, very serious condition, and it's E. coli. Not saying it's from water, it could be from many things, but does the health unit get notified of that and you follow up?
Yeah, so we are sort of stepping into a different program here, but the infectious disease program, there's a list of notifiable diseases, E. coli being one of them. And if we're notified of a person contracting one of those diseases, then our infectious disease team do case contact management and follow up with that.
Oh, okay.
Yes, Mr. Chair, thank you. Just wondering, we've just just heard two extremes. We've heard that the testing is basically under what it should be generally, but that the 10,000 number is skewed by one individual, for example, who will have testing every day. So that speaks to me about fear, possibly, fear that would drive somebody to test every day. And at the other extreme, possibly fear that would maybe prevent somebody from having their well water tested, maybe out of concern as to what would happen next. And I know that our public health, we have an excellent communications branch and staff, but I'm wondering if they're using any of their messaging to address potential fears on both ends here, that one doesn't need to test every day, whatever that fear might be that's driving that behavior. And at the other extreme, if there's a fear that, if there's something wrong with my well, I might lose control of my property or bad things might happen, if there's perhaps some way that we're designing our messaging to answer those fears. Thank you.
Thanks, Dr.
Yeah, through you, Mr. Chair. Again, excellent questions, and I'm really pleased because you're gonna see in the presentation slides related to communication on the subject. The University of Queens and Public Health Ontario, that's the provincial level scientific branch for public health, both evaluated the issue and they found two main factors for the less than optimal testing. Number one is the lack of awareness of the risks. And the second one is lack of awareness of availability of testing. So those are the two factors that would probably bring turn the ship around. And this happened recently. And like Andy mentioned in the outer general report, there is the advocacy, or not the advocacy, the direction to the ministry, the provincial ministries to focus on this. Locally, we do have the communication. We've had this campaign, paid advertisement, all these things, and we issue a media release specifically around the springtime where the appropriate testing happens. And we will continue to monitor and see. But whenever there is the outlier person who's testing every day, that communication happens one-on-one. And I believe Andy spoke with that individual person who tests every day to say, their advocacy was to keep the testing pickup center in the grocery store because that's where the person goes every day. And it's like, we can't do this. We need to centralize it for all Grey Brews, and we're going to ensure everybody would have access to it. It is definitely something that we will monitor going forward and adapt to, and the messaging will adapt to it. But currently, the main messages is the testing is available and the risk is real and still exists.
Through the chair, in the piece that is to the public, is there anything that alludes to the fact of what the remediation is? Like, do not fear, just going on what Helen Clare spoken of. Like, it is so much better to be safe, and this is all that it entails.
Mr. Chair, the main message there, the second main message would be to contact the health unit. We would interpret the test for them. We would provide advice based on the well. There are, as you can appreciate, wide spectrum variety of systems, and each one would have different level of risk and requirement to follow, and it's private. So unless the person requests and provide that information, we have no knowledge of it.
Yeah. Thank you.
Thanks, everyone. Dr. Rao, I'll turn it back to you for Dr. Bourne.
Thank you, Mr. Chair. And again, the next item is with Andrew, the lead and British.
Dr. Aaron, again for you. Yes. Again, our recommendations the Board of Health received for information in the report, and it provides an overview of the vector-borne and rabies programs, activities, and planned next steps. So, key points in the report: vector-borne disease surveillance is ongoing. We use the results of that to assess the risk from these diseases, provide information to clinicians, and guide human health treatment. and also inform public health messaging and promote risk reducing behaviour. So the risk from West Nile virus and Eastern equine encephalitis virus, which from now on I'm going to call EEV, it remains very low and relatively static in grey roofs. Switching to rabies, the number of rabies animal exposure investigations has increased in recent years, particularly last year. Public health activities manage the risk following exposure, so typically a bite, and assist the public in accessing the correct care when it's required. The data from that program also helps us in making evidence-based and risk-based decisions. And then the sort of final point there is that the increase in investigations does not indicate an increase in risk to the public of acquiring the disease, but the risk of acquiring rabies across grey roofs remains very low. So I do have some initial points as well that I'll pull in from the report. So the environmental health team develops, implements and maintains an integrated vector-borne disease management strategy. So we're looking across multiple potential exposures. For the mosquito vector species, so this is things like EEV and West Nile virus, we do active trapping through the summer season. Because the levels are low and relatively static, we're really aiming just to get a sense of what the risk is. So we trap across all 17 municipalities. Captured mosquitoes are sent to a lab that conducts identification and viral testing. As a sense of the scale of that, last year we did 87 traps. Proportion of mosquitoes that were potentially vectors for West Nile virus and EEV was low, just over 3% of the mosquitoes that were captured. And that's actually a slight decrease from the year before. Potential bridge vectors were more prevalent, just short of 50%. And we had no positive pools for EEV or West Nile virus in 2024. Now, provincially, that's not necessarily the case. There are a number of positive pools and some higher numbers, particularly further south, where the number of degree days were a little bit higher, particularly last year. So although the risk locally remains very low, the provincial data does show that ongoing surveillance, is still an important part of public health intervention. Changing gears to rabies there. Rabies is essentially 100% fatal if left untreated. Epidemiological evidence shows us that the risk to humans from rabies in Ontario, or locally Ontario acquired, is very low. However, 2024 saw the first provincially acquired human case since 1967. It's a rare event, but a tragic event, and it reminds us of how important the program is. So in 2024, Grey Roofs Public Health conducted 722 animal exposure investigations, and that's an increase from 592 the previous year, and that in itself is actually an increase from more traditionally we were in the sort of low 500s. So it's a good 30% increase on what we traditionally have seen. Now, most of those cases, further action wasn't indicated, but post-exposure prophylaxis was indicated in 104 of those cases. So as conclusion, the surveillance and investigation activities conducted as part of vector-borne disease and rabies programs are foundational to public health protection, and they exist to make sure, of course, the health of the public is maintained.
Through you, Mr. Chair, to either Dr. Era or Andy, I'm curious to know if the Board of Health, if the health unit monitors ticks at all and at risk with contracting Lyme disease.
We do, and I was in two minds whether to include that in the report as well. The reason I didn't actually is with 2024 being a cool year, there were no additional high risk areas found last year. So essentially, the report would be very similar to the previous year when we did do a tick report. But yes, we do active monitoring for ticks as well. tick dragging. And that is basically looking for black-legged ticks, so the vector of Lyme disease. You might be aware Lyme disease in humans is increasing. There's been a steady increase since about the year 2000 or so, going from maybe just a few hundred cases up to over 5,000 cases last year, provincially. So it's certainly something that's important to continue to monitor. We use the same vector species management for that. So we essentially keep an eye on complaints, on passive surveillance information, and we use that to direct where we'll do our active surveillance. We're essentially actively looking for these ticks. If we find ticks spring and fall in the same area, and the evidence shows that they're actually established in that area, then that evidence goes to the ministry. Public Health Ontario and the ministry produce a black-legged tick risk map, and Grey Bruce does have areas on that. In fact, about a third of Grey Bruce are shown as high-risk areas for that. I wouldn't want to guarantee that there are not black-legged ticks outside of those areas. Obviously, they do spread, and they're particularly carried by birds, migratory birds. So that's likely why we've seen that sort of northerly movement into Grey Bruce. So it was only, certainly if you look back 10 years, I think we maybe had one high risk area. So there has been an expansion, but 2025 map is the same as 2024 for Grey Bruce.
Thank you.
Thank you, Mr. Chair. Thank you for the excellent presentation again, Andrew. Question about rabies. It's great that it's rare. It's horrible that it's tragic when it occurs. Are bats still the primary purveyors of rabies?
Yeah, in Grey Bruce, they are I would say, the main kind of vector species of concern. That wasn't the case 20 odd years ago. You know, we had rabies in terrestrial animals. It was not uncommon to find rabies in skunks, raccoons, foxes, and overall the amount of animals that turned up positive was much higher than it is now. You might be aware that the Ministry of Natural Resources initiated a process where they do aerial drops of bait, and those terrestrial animals would consume the bait, and it would offer them protection. That's been a very effective process, and we have not had a positive terrestrial species. So any of those species we have not turned up positive for rabies in, I think, around about 10 years now. So if we look at that most recent period, we do still get positive bats. We do know that the bat population continues to carry rabies. So again, you know, we're always cautious if whether it be a dog or a fox, we conduct the animal exposure investigation to make sure there is no risk to that person. But certainly bats are the ones that we are aware are probably the most risky.
Thank you.
And just on that question of the rabies investigation program itself, just kind of that increasing trend of the number of investigations. Obviously, I know in the report it kind of mentions that some of them are kind of keeping an eye on to see if that's kind of an entrenched upward trend. What do those investigations look like in terms of staff time? And I'm assuming each one is probably a little different, but just wondering if you could speak to that.
Yeah, it's a very good question, and it's actually part of my concern for that upward trend. They do vary a lot, but some of those investigations are quite time consuming. Even where it's a domestic animal, it's a dog, it's unlikely that rabies is the reason why that dog has bitten somebody, but we have to eliminate it. And that process can result in multiple calls, emails, working with other agencies, whether it be bylaw or occasionally even the police services. Some of those investigations are extremely time consuming. So that 700 number, that's not 700 phone calls, that's 700 investigations. And some of those investigations can literally be days of time, days of FTE. So that 30% increase is quite significant.
Yeah, I mean, through you, Mr. Chair, and to add to what Andy mentioned, if there is potential risk of rabies. Now we're communicating with the hospital or a healthcare provider or both and the family to ensure the vaccine is delivered and there is a cold chain and there is many logistics behind it, and we're available 24/7. And usually these things happen on Friday afternoon. So the whole weekend sometimes is spent to support the public. And worth mentioning, the number itself is 700 or even 500. And we looked at it and how can we reduce this? How can we ensure the public is not exposed? And it's multifaceted. Many of these people who get exposed are not from the health unit. So all the messaging locally, there are visitors, somebody comes here and goes to pet a raccoon or pet the, what was the cat, Fisher cat.
We had a Fisher cat, yeah.
So the whole family was exposed and now we have to communicate with another health unit to coordinate that information going back and forth. These investigations are quite time consuming, resource consuming, and there is a communication element of it for each one that we're not going to be able to identify the animal or we're going to call on public with a media release or different messaging.
That's something to keep an eye on, 'cause, yeah, I'm assuming that pulls from other areas of focus, correct?
It does, and actually that's pretty key to me mentioning that it's the same team of 12 and the two PAs that do, whether it's the food inspections or the looking after the safety of the pools or the rabies follow-up. So that time comes from somewhere. Yeah.
Excellent. Thanks, appreciate that. Therefore, thank you for tonight.
And tobacco's with Janelle or
He's on there, yeah.
oh, he is online.
Yeah.
Good morning, members of the board. Through you, the chair, like to provide the report on the tobacco enforcement program. It is my recommendation that the Board of Health receives this report, which provides an overview of the program activities of the tobacco enforcement program for information purposes. The report highlights the gradual decline in youth nicotine use. In 2021, 15% of students in grades 7 to 12 reported vaping, whereas in 2023, the proportion dropped to 13.4%. The tobacco enforcement team continues to work and collaborate with other teams in the health unit, as well as other community stakeholders to develop and implement strategies to achieve further decline in the proportion of youth nicotine use. With the recent establishment, that was in the fall of 2024, of the first hookah lounge in Gray County, the tobacco enforcement team is advocating with the municipality to consider amending their bylaw regarding smoking and vaping of any substance. The team is also currently working with the school health team and school boards to establish a vaping diversion program for youths caught smoking or vaping on school property. This partnership, which started in the 2023-2024 school year, has yielded 78 referrals, of which 40% reported reduced vaping use, while 10% of those referrals plan to quit smoking. In conclusion, the tobacco enforcement program remains committed to reducing the burden of tobacco use within Grey Bruce. It hopes to accomplish this through education, community partnership, diversion strategies, and progressive enforcement. With that, I'm available to answer any questions members of the board may have.
Thanks so much, Sharon. Any questions on the board, Jay?
I probably ask a question that has been asked in previous boards is why, when the province brought in the legalization of or the feds for marijuana and smoking, did they not put that under the Alcohol Act? I can't go 20 meters beside a building's door and have a beer in my hand and drink it because it can cause me to be drunk. But I can go 20 meters beside a door and smoke a marijuana cigarette and get buzzed out of my tree and walk down Main Street of the town. So why is it not under the Alcohol Act? Why is it under the Tobacco Act?
Through you, through the chair to the board member, that's I have to confess that's a difficult question for me to answer. Why it is why the province went in that direction. I'm unable to respond to that. I don't know if Dr. Era has a word or two.
Well, is it something that we could send a letter to the province asking that question? Because I keep asking that question wherever I go. And I have been asking that question ever since they brought the legalization of marijuana in. But why can I stand in public and not drink a beer the same as smoking a marijuana? Like what, to me, it's the same thing.
Yeah, through you, Mr. Chair, good question, and I'm like Shamir mentioned, our work is very prescribed, so we follow these standards. Have we advocated as public health to the provincial level to mitigate for this factor and many other factors? Yes, the answer is yes.
Okay.
Absolutely, and there are many other questions. You know, you look at vaping, for example, was regulated and made available a few years ago, and the numbers have started turning the tobacco success that we had over the 30 years backward. There are more people who go on vaping than use nicotine down the road. The report, the second year vaping was in the market, there was a report from Johns Hopkins. Johns Hopkins is one of the most credible medical schools in the world. The pathology report of people who died with through vaping for a year or two. The report, I recall when I'm reading it, was strikingly memorable. Strikingly memorable. The assault on lung tissue from vaping is very similar to the assault from mustard gas that we have experienced since First World War. And you know, this product should not be in the market, should not be marketed for kids. Some of it is on colorful candy. You would see what the target audience is when you see these products. And that's, you know, there are these questions, why and how can we ensure that we would advocate and would show the numbers that this is not helping the case of protecting the health of the public. It continues to happen through many channels, whether it's Alpha, the Health Unit, the board's resolution. The question specifically on its own, I don't know if there is more meat in sending it to the ministry to get the answer. Most likely the answer is going to be there were consultations when these laws were taking place through the second reading. I don't know if there was consultation with the public or just in the chambers. But I don't think the answer would change our level of advocacy for it.
Yep.
Mr. Chair, if I may, and like based on this chair too, you look at the hookah launch response. This is for them, like mainly we work with municipalities to increase their awareness about this, the trend that can happen and happen in other parts of the province. You know, people see it as different from tobacco. It's very similar on many fronts and could be worse on some. The hookah, forgive me getting technical, the hookah chemicals or chemical reaction is alkaline. Tobacco is acidic. So when a person takes a puff from cigarette, usually there is a reaction of coughing. With hookah, it's actually soothing to the bronchi, to the air channels, and that increases the amount of smoke going into the lungs all the way periphery. And cancers that you would see with hookah are spread throughout the lungs more than the centralized tobaccos. So again, you know, when it's marketed to the public as a benign habit, it's not. And you know, you go back to Helen Claire's question about the messaging for water. There is messaging that need to be done on many fronts and, you know, you would worry about messaging fatigue. We are messaging everything. So we try to be very strategic in our messaging. And water is important. This is important. And we would have just to be very efficient and strategic and long.
Done.
I have to be careful in this one. I'm a 30-year smoker that had quit 13 years ago. So my thing is, I think we need more enforcement. It is disgusting to me now that we got all these rules, and every time I take my grandkids to a sports facility, you walk out the door and everybody's around it. You take them to a Leaf game in Toronto and you come out, you're trying to teach your kids right, all you can smell marijuana in the air. You can't get away from it anymore in the cities, like Jay says. And I think if we hit people in the pocket, it will change their perceptive on where they can do it and where they can't. So it's enforcement is a big thing, and I know it's out of our hands, but it's something we could advocate for, is to have more enforcement around sports facilities is where I see the biggest problem.
Ellen Claire?
Thank you. I just wanted to take a moment and celebrate for my honorable colleague who has stopped smoking all those years ago. I have read that stopping smoking is harder than heroin, and I have lost members in my direct circle to cancer related directly to smoking. I agree with my colleague's position that we need to do more to prevent people hopping on, and I'm deeply disturbed that I hear regularly from young people who really believe that it's A, better than smoking, or B, a better way to stop smoking. So, and finally, to my honorable colleague's comments about writing letters to the province, if we're going to write letters, I would like to sign a letter to the federal government asking them what were they thinking when they legitimized marijuana, because absolutely you go to any big city and try to walk around and you are breathing somebody else's secondhand dope.
Everywhere.
Thank you for that rant, for allowing that rant, Mr. Chair.
Thanks, Ellen Claire. Any other discussion on the report from Shamir? I have a quick point for me. The program outcomes on the vaping diversion referral program, of getting into schools and talking directly to students, I think is an excellent partnership to have. And I know firsthand from my wife, the child and youth worker with the Blue Water School Board, and some of the programs she works with directly deal with the vaping education for students, and it's looking at the key outcomes. Only 2 students reoffending and 50% reporting behavior change. Like, congratulations, that's excellent. Excellent.
Thank you, Chair.
All right, over to you, Dr. and for those goals. Please do.
I can. Okay, thank you, Dr. For you, Mr. Chair, I will note when it comes to questions, they're probably better for Dr. Ara to answer, but I will do an overview here of our tuberculosis prevention and control program. So our recommendation is that the Board of Health receives for information this report, which contains details on our TB prevention and control program implemented by the infectious disease team at Grey Bruce Public Health. The key points from the report: tuberculosis is a serious life-threatening disease which continues to impact people around the world, including Grey Bruce. TB elimination is a national and international goal, of which our local TB programming helps to support. Locally, clients with a TB diagnosis face many challenges, including access to and navigating services required in what is often a lengthy course of the case. So we do provide ongoing support from public health nurses and efforts to increase local healthcare provider knowledge as well, to increase awareness of TB and related care assistance in early identification, preventing the development of TB disease, and of course subsequent transmission as well. Some additional notes. So TB is a serious bacterial infection. It's still the leading cause of death due to infectious diseases across the whole world. killing more than 1 million people globally every year, despite being preventable and curable. About 90% of people who become infected with the TB bacteria do not develop TB disease symptoms, and they, at that point, cannot spread the disease. So that's called TB infection. And then if you do move to TB disease, that's the point where it becomes infectious and can spread to other people. If the germs are found in lungs or airway, people with active TB disease will feel sick, and without treatment, active TB can be fatal. So in Ontario, the incidence rate of confirmed active tuberculosis cases has been on the rise just recently. It declined between 2006 and 2014 and since started to increase again. In Grey Bruce specifically, relatively low numbers, so about 1 case of active tuberculosis disease every other year. We do more commonly get reports of inactive latent TB infection. So we had 19 cases of that in 2024. And that is a marked increase over the last 5 years. So TB disease is treated using antibiotics over the course of multiple months, usually 6 to 9 months. Due to the challenges of this treatment regime, the treatment is usually done under direct observation. So that means a public health nurse watches the client take their medication every day for the duration of that regime. So you can imagine it's a fairly significant piece of work. Additionally, Grey Bruce Public Health's infectious disease team has been working to increase primary care provider knowledge of TB detection and treatment, such as including information in our monthly primary care provider newsletter. And we are also exploring future opportunities for delivering education in the communities as well. So overall, the tuberculosis prevention and control program is complex but important work, and the activities carried out throughout the program help to protect health in our own communities and also support the national and international goals of TB elimination.
From the board. Dr. back to you on the vaccine program and your report.
Thank you. So, sharing my screen. So the annual report on privacy, the key accomplishments, I believe that summarizes most of it. And there's a summary at the very end of the requests and breaches and others. It's worth mentioning, historically over the past 10 years, we had different models to deliver. One of them is partnering up with a neighboring health unit to use the same privacy service. As a small organization, hiring a person full-time might not be the most efficient way, so we partnered up with an organization. During the pandemic, there has been a number of changes, so we went back to the model of contracting it out, hiring a specific company, and the company had an individual who's very capable, Nicole Gother. She's our privacy officer. So over the past year, we looked at reviewing the whole program and updating certain things to meet the new regulations, reviewing all policies, and there's a list of things that happened there under the policies changes. Privacy, freedom of information, content, public website, putting things on our website related to privacy in many forums. Privacy training, that's a mammoth task, actually, just because, the privacy regulations are very clear to certain professions. It's not very clear for others. Nurses, physicians learn it all the time. So we had a session internally for 2 days to provide the training, and delivered a very, very customized version of privacy for health units. That's other challenge. Usually privacy is taught in the healthcare system and hospitals and others, and we have different arena. We work in the public arena, and we need to maintain privacy. And a module was created and the staff engagement in the subject and feedback has been very, very excellent. We worked on a number of reports or a number of incidents. There was privacy breaches, two of them, both of them addressed promptly. Reporting happened to the individuals affected and to the appropriate provincial level. The number of requests are there as well for privacy related reports and I believe all in all we are in a very good position with the local program, having it in health unit, customizing it to what we need instead of cost sharing with other health units. We might consider down the road offering the service to other health units if they're interested, so long that we have the control over the maneuverability of it.
Discussion from the board. Perfect. We'll move on to the much anticipated presentation.
Thank you. That part is already kind of covered with the questions. I still have questions. Let's see how I can share this. I'm using the same slides that were used for the presentation through the Washington Clean Water Center. And we had a presentation in the 25th anniversary earlier this week, and it was attended by over 300 attendees, and they are usually the water operators and people involved in clean water systems. And the panel, it was an honor to be on that panel with the high caliber water experts, including Justice Dennis O'Connor, who wrote the report for the Walker. It was very excellent group of experts delivering their messaging to the operators, and I believe it's posted as well for the public, for private wells owners to listen to. Just trying to move the slides. There we go. Yeah, the disclosure that's usually disclosed that there is no conflict of interest. As you can see, and you know, the public sector doesn't really exist. We'd like to keep it that way, so there's no conflict of interest. Small drinking water systems, privacy, private water systems, and public health tools. I thought that I would share with that group and with the public right now what we do in the background and how we ensure that if an incident happened, it is already addressed or there are tools that address it. So the legislations that ensure drinking water is safe in Ontario lends itself to two laws: Safe Drinking Water and the Health Protection Promotion Act. And that's the second part. That's what we deal with as a health unit. We deal with the small drinking water systems, and as I mentioned before, it's access. Public access is what defines the system. There are a wide variety of what these things could be or where they how they're identified, but restaurants, hotels, B&Bs, anything where the public can just access water, becomes our responsibility to work with the operators. Owners and operators' responsibility, and again, some of these slides are very technical for the people who made the drinking water safety their job. So it might not relate to what we do at the level of governance of the health unit, but out of the complete, and I included them. Public health inspectors' responsibility. This is our team. We identify these systems. We educate the owner operator. We do risk assessment, and it's a very technical and robust approach that's to ensure each system is assessed in an appropriate way. Issue directive. These directives is what the marching orders would be the operators and owners. Monitor standards and compliance, response to adverse results and observations, response to complaints, and public disclosure. And our team does an amazing job. And again, like in the memory of the Walkerton tragedy, it's important to emphasize the level of responsibility that's on the shoulders of people who make safe drinking water their career and job. Every child who is 3 years old would know that firefighters and police, it's an amazing career and they save lives. And we are the victim of our own success as health inspectors, as even, the operators and the water experts who work in the municipality, in the community to ensure drinking water is safe to a degree that we forget about it. As I said, of water, nobody thinks about the risk. I'm taking this opportunity to celebrate and appreciate our staff and everybody who works in water safety. Risk assessment, as you can see, it used to be on paper, now it's online and it has multiple forms, including paper too still. And there are the directives, there is a description of them here, and they're related to the people who operate the system more than the public or the governing body of the health unit. But you can see in general, they're very site specific. Each system has its own history, its own manufacturing and instructions from the manufacturer, the experience that the operator has, how many incidents, all these things are factored in, and our team would evaluate that and work with the operators to ensure the water is safe. Sampling requirement is depending, like biological sampling is absolute for everybody, but there are other samples related to chemicals and minerals. And again, it's a well or system specific. Operational check. We work with the operator. They're required to conduct their own checks on the system related to the level of chlorine, turbidity, and other factors. And it's worth mentioning that record keeping is essential there, and I do believe this is well established through the report itself, through the tragedy and the importance of it. The systems have redundancy in them, so there is a record with the operator, record with us, record available for everything, more or less. Operator training is another layer that's well refined in Ontario. And it's prescribed in protocols and regulations. And monitoring the systems, how the public health inspector monitor, review water sampling, we follow up during other routine inspection, assessment, response to adverse water qualities, complaints, others. And we do visits, we do visit each small drinking water system every 4 years if it's low risk or moderate risk, and every 2 years if it is high risk, and sometimes more frequently depending on the need of it and the situation itself, to follow up with the operators. Adverse events and observations, and events. Observations can happen based on a visit or based on what the system history is, and the events may impact the water quality being supplied during the testing or for adverse events. They're very consistent in the way we respond to them, and they start by identifying it to the MOH office and to people who are affected, and we do many things in the background if that happens. And there are many resources, whether it's small drinking water system or private. We have resources on our website, and MSP has resources. I do believe the drinking water system changes that happen after Walkerton make Ontario second to none. We included also in that presentation 3 slides on private water systems. And many residents, as like the same discussion that we had already, I'm really pleased with the engagement and questions. It addressed everything. Whereas you can see that, the testing is less than optimal. The Auditor General Report 2025 identified this, and there has been work on it from many levels, including the ministry as well. And the two main reasons identified from Queen's University and BHO is lack of awareness of the risk and lack of awareness of the availability. And there's that summary of what the health unit done here locally, and I believe that we are the only health unit that went that far to take ownership of the issue and work on it, although it's not in our mandate, it's provincial program. And we have 14 locations. We continue to respond to the communication itself, the communication need, I think. Put this help put all these slides related to the water system. And I believe the Southwest Group for drinking water system has credit in putting these slides as well.
Yeah, the slides on the small drinking water system specifically are loosely based on that group's small drinking water system operator training.
Yeah. So that was great work that Andy every following year. Those are the main messages to the public and operators as well, to test their water, to contact public health. If these two things are delivered to the public, and we will do our best to continue to do this, I do believe many people will believe it. I included again to that group and to the public here the list of tools that we use, epidemiology and health surveillance. There is history there for the water. This gentleman from England from the 1854 is named John Snow, and totally different from the John Snow in that show, TV show. John Snow was a physician who used epidemiology, and he is known to be the father of modern epidemiology. There was an outbreak of cholera that is substantial in London and persevered or continued. And this gentleman famously went to a new method called mapping analysis to identify where these people live and where is the source of cholera, and it wasn't their water, and identified this specific water pump. And famously, he removed the handle of it, and the outbreak ended. It's still in England if people visit one day. He used this map here, and I included it eventually along with another map from back in the day, 1918, which was the influenza pandemic, the Spanish influenza pandemic. And I have a point here to deliver. You can see a small wave in the spring. This is the spring of that year. Then there was a huge wave in the fall, and a third wave that's mid-size. And influenza and COVID has very similar characteristics of spread. So when we finished the first wave in the spring, many people were like, the pandemic is gone. But it was very easy conclusion for anybody who works in epidemiology and public health to say, like, the mammoth is coming, like we haven't seen it. And it was the second wave that was the biggest, and the third wave. So again, there was a lot of value and meaning in epidemiology, even with the relatively primitive analysis that happened at that time. Then you can skip to today. We have way more advanced tools with computers, and now AI is coming. It's going to even add more. We look at as early as child care absenteeism or school absenteeism. Before people make it to the hospital, we can identify a signal to say there is an increase in this disease, and it's localized to this area or not that area. And we look at the ER visits, we have access to the paramedic data if need be, and obviously lab results will come to us. So again, at the time, the Health Unit was successful to identify that there was something wrong with the water in Washington. We do have way more tools today to ensure things are not going the right direction. And this map is for COVID, but it's the data is available for any infectious disease. And we're able to put these dashboards for any disease based on need for it. And this is, I don't know if it's gonna open on this, it didn't open. I just wanna give a second to show. Open. This is Surge social analysis specific tool that this is for COVID, but again, it can be studying any disease. We follow each case. We know who was infected from who's a carrier, and what type of situation it is, and we can do many things, and we do it in the public arena, but ensuring privacy and confidentiality to the best of our ability. We only identify when we need to reach to certain people that we don't know their names. Like if there is exposure in the ER, we go to the record in the hospital, we work with them to identify who was exposed to measles. And we reach to these individuals and say, who was with you as a visitor in the hospital? And that's a scenario where the public is not gonna see other than just there was an incident. But if it is, let's say, a bar where there's no list of people who went in and out, we would issue a media release, reach out to people and say, if you were in this time, between this time and this time. Again, there are many tools that would allow us to do excellent.
You'd get everybody coming forward from the one back in your report earlier of Danny's bar.
We issued that because we knew who was there and worked with them, but there were many people who weren't there.
Yeah.
So
I just laughed.
there is something else I would let them in. If people don't disclose, down the road, we're gonna identify other cases that were infected from them, and we can retroactively work back to them. So if we interviewed somebody and they said, and this happened during the pandemic, somebody said, I'm in isolation. And after a while, we identified a person and we said, I spent time with them. So we went back to them and said, we can issue an order, which would be very costly legally and financially. And when they realized the consequences and our ability to identify more people, they came up with a list of 30 people who actually, through their business, were doing business with. So again, there are many tools to identify, even if people don't come forward. Just hope they will do it for their own health, mainly, and the public setting. That's legislative authority. We do have the ability to do these case management, contact management, outbreak management, to identify individuals and groups. And again, we ensure privacy is absolute and for everybody. Communication, this is what I would say I was referring to. There are from EPA and from CDC, the Center of Disease Control, the same cardinal rules of communication, and I do believe the use of them here over the pandemic give us so much credibility and allow us to do our work. And during the walkout, and I go back to the report, they were used, all of them, although at that time they weren't done. So kudos to the people who led that process, and Justice O'Connor, obviously. All these things happen, partnering with the public, there was public engagement, plan, evaluate, listen to the concerns of the public, be honest, frank, and open, and coordinate, collaborate with other credible sources, meet the needs of the media, speak clearly and with compassion. And like any example, a school case or an outbreak, this is a list for COVID actually, where between 7 a.m. till 7 or 9 at night, Drew, the previous media coordinator, and myself, we were here And we're doing this list of communication every hour, sometimes less, depending on the partners. We communicated with the media. We had, like, I believe, 9 interviews, and that TV interviews and radio interviews for that situation. Board of Health obviously knows what we do. There's school officials, the directors of education, and they can communicate. Because as soon as there is a situation, there is a rumor that the thing is bigger than what it is. So we communicate to them, we tell them we already know the cases, and anybody who didn't receive contact from us has not been exposed. The wardens, mayors, CEOs, MPPs, the hospitals, sometimes they get flooded with requests for testing when it's not necessary. The Ministry of Health, neighboring health unit. And again, communication is key. Too much of it is not too much. Too much is not enough when it comes to emergencies. And risk communication, this seems like a simple graph, but it is really key, and we use it more like on daily basis multiple times during the emergency. We use it, for example, for water testing. Helen Claire's comment that there are people who are too concerned, people who are less concerned, and how we can bring these people to the happy medium. If there is an issue that has a lot of hazard, which is the real risk, outrage is the public's response to it. And I should reference this is from Peter Sandman. He's a physician who made a career in subspecialty in communication of public health issues. How to take something like, if you look at this orange, people are outraged, but there isn't really huge risk. Wind turbine. Nobody died of wind turbine for the past 20 years, but at certain points there are huge outrage. People, attacking presenters when it comes. So how can we reassure them, bring them to the happy medium so people can follow what needs to be done in crisis communication? When there is a real crisis and there is frightened public, the public does not respond, does not do what they needed to do to protect themselves. So we need to reassure them that those are the things that we're doing. Those are the things that you as an individual, the public, can do. This is what the establishment is doing, and ensure everybody's in a happy medium. And obviously, if there is a lot of hazard and people are not aware of it, like back in the day, where it's lead in the water in certain occasions, we have to bring the level that, yeah, you don't see lead, but it's actually affecting anything and everything you're doing, especially the IQ of kids. So again, we do those things. Innovation, there's a long list of things public health can do, and I hope in the future we'll continue to do. And here's the credit I was looking for. Sorry, Andy, asking you there. I know that you put it there too. Southwest Small Drinking Water System Working Group contribute to the slides that are related to water testing. And yeah, we continue to work with the public and partners to ensure safety. And
Questions or discussion of the presentation, Rebecca? Seeing none, and we had a lovely discussion previously with the morning, so that's great. Perfect. Thanks to you, Dr. Ara, Shamir, for really a great update from Officer of Health, and is that good for mover in a seconder that the medical officer of health update be received by the Board of Health for information. Moved by Bev, seconded by Dawn. Any discussion on that motion? And all in favor? And that's carried. Perfect. Thanks so much, everyone. Moving on to the corporate services update, I would turn things over to, I think Kim's online today, so over to Kim.
Thank you, Mr. Chair. Through you, this is the March 2025 financial results for Grey Bruce Public Health. So as of March 31st, we're reporting a total surplus of $433,000. Broken down with $321,000 of that relating to our mandatory programs and $112,000 related to the seniors dental program. Looking at revenues, year to date, our revenue is slightly under budget. This is mainly due to the lower than expected expenses for the COVID-19 vaccine and RSV programs, which in turn resulted in reduced eligible one-time funding from the ministry to cover those costs. All other revenues were tracking as expected. For salaries and benefits, we're seeing a favorable variance of about $173,000. This is largely due to some staffing vacancies across some roles while we finalize recruitment. We also have some of the support gapping in the parent support worker role in the HVHC program, which operates on an April to March cycle. So this amount is cumulative from April 2024. And then lastly, in March, we received a WSIB surplus distribution, which was a credit from the amount that we paid in premiums for 2023. And that's significantly reduced our year-to-date WSIB expenses, which has resulted in our year-to-date benefit costs being under budget. Our occupancy costs remain within our budgeted expectations. And for our operating expenses, most categories are under budget, which is common for this time of the year into the fiscal year. So that's mostly our materials and supplies, professional development, travel and IT budgets. For the dentist and dentist fees, the costs for that line is lower than usual in Q1. We did dig into it a bit further, and we've just had a reduced need for denturists in Q1 and lower use of the operating room procedures, which could be partly attributed to some of the winter weather we had. So the dental team's currently exploring ways to optimize the use of that budget for the remainder of the year. In the capital fund, the interest earned on our capital reserve is above budget, and our capital expenditures are on track. We've got 2 projects that were budgeted for currently underway. The window replacement procurement is completed and the contract has been assigned, and that work should commence soon. So overall, we're in a strong financial position as we head into the second quarter, and we'll continue to monitor our expenses closely to ensure our funds are utilized as the year progresses. And happy to take any questions.
Excellent. Thanks so much, Kim. As always, any questions or comments from the board for Kim? Jake?
Just on occupancy and internal rent and mortgage. Is that income to us? I'm just looking at funding expenses operate, or is that an expense to us?
So through you, Mr. Chair, the internal rent mortgage, so that's it's an expense to the mandatory programs. So that 90 or the 270,000 you're seeing year to date, that goes over to the capital statement. So you'll see that as a similar amount on the capital statement as income on the capital statement. And that's covering the mortgage and interest payments on the building out of the capital fund.
Yeah, so it costs us roughly an annual budget of $1 million to run this building.
Through you, Mr. Chair, that's correct, yes.
Because I had asked this question before on, are we gonna see something on what we're gonna do with this building in the future? If it's gonna remain half empty, should we be looking at other sources of income or ways to create income for this building so that we can reduce the cost and use these dollars in other programs? Okay.
So through you, Mr. Chair, so there's both. We're looking at the utilization of the building, and we're also looking at ways to expedite paying off the building. So the mortgage payments. So if the mortgages get paid off sooner, then that frees up those operating dollars for other things versus the mortgage payment and interest.
Yep.
Any other questions? None. But I would look for a mover and a seconder for the motion that the financial reports for March 2025 be received by the Board of Health Care Commission. Moved by Shirley, seconded by Ken. Any discussion? Being none, all in favor? Here, moving on to item 10.0, and this just to remind the board, we moved the presentation on emergency management to this section, so perhaps we'll begin there with the staff presentation on emergency.
It's gonna grab the staff number.
Okay, great. Sounds good.
Good morning.
You get the head of the table.
Yeah.
Welcome. The presentation.
Clear, yeah, Danny is the manager for foundation standards, and she's taking care of the emergency management portfolio. She's a very capable lady who worked in Public Health Ontario, worked in other very effective roles, and we're very lucky to have her on our team and has been with the health unit for 2 years now.
Welcome.
The emergency management report first. Did you include that?
Good afternoon. So, the report is just an update on emergency management at the health unit. The recommendation being that you receive this, as information about emergency management and planning at the health unit. The key points being that emergency management is a crucial aspect of public health, and we are required by, various legislations to be prepared for emergency situations, and that we as a health unit we do have plans and policies to address emergency management. So a little bit about emergency management. It is one of the foundational standards of the Ontario Public Health Standards, and it requires that we have a comprehensive approach for prevention, mitigation and preparedness, response and recovery from emergencies. In Ontario, there are several organizations responsible for emergency management, including Public Health Ontario, Emergency Management Ontario, and the Ministry of Health. And the Ontario Ministry of Health, under its authority, which is derived from the Ontario Public Health Act and Emergency Management and Civil Protection Act, it plays a key role in emergency management in Ontario. So now looking at how we prepare for emergency management, how we prepare for emergencies at Grey Bruce Public Health, in compliance with OPHS guidelines and regulations, we have put together a Grey Bruce Public Health Emergency Management Committee that includes management representatives from the various health units programs. And I lead that committee. The Emergency Management Committee has updated our documents, which are required to be updated annually. But because of COVID and a few things were a bit behind, so we've updated the hazard identification and risk assessment, the emergency response plan, and we're in the process of updating our business continuity plan as well. So just as a background, the hazard identification and response, the HERA is the key component of the health unit response plan. And we have used the guidelines from the ministry, the emergency management guidelines from 2024. And then based on the assessment we conducted late last year, we identified 10 key hazards. So we have to identify 10 key hazards based on the probability that they will happen and the impacts or the consequences if they do happen. So we identified this 10 possible hazards or emergencies that we could face. Also, the emergency management policies that we have recently updated includes the adverse weather and emergency closure policies, which outlines how we would accommodate employees in the case of weather-related office closures or other closures. And since I wrote this report, we have conducted the rave alert notification exercise. So the rave is a system for informing staff and partners if there was an emergency. So it goes to emails, telephones. I think various other organizations use it as well, and we might have received from a few organizations. And so we had that on May the 14th, and it did go well. We had an after review to see the things that worked well and the things that we needed to improve upon. And just as information, we are a member of the Ontario Public Health Emergency Managers Network, and we meet 4 times a year. I think that's it.
The questions or discussion on the work done?
I spent time at the OSIM conference in Collingwood a couple weeks ago. Can the health unit operate if we have a cyber attack? Like the mayor of Stratford spoke, and it was devastating what I would call devastating what they went through, because they had no computers, they had no cell phones.
Mhm.
Could we operate without? Like everything today, I looked the other morning, there was a bell was down for 3 hours in some areas, right? And CIBC Bank had to shut down and stuff. So where are we at? I'm not sure it really falls underneath you, but it is. We are kind of in a state of emergency. If we have a cyber attack, will we lose internet connections or cell service?
Through yours, through chair, I am not expert in IT, but I know firsthand from working with our IT department and what the results they bring forward. We are in a very strong position to ensure the integrity of our system, to ensure privacy. As an organization that's connected to health, we always have heightened alert and heightened response to and arrangement for that, ensuring the safety of the system. So we do exercise everything we can exercise on that front. And I can give a couple of examples where, organizations might remind people about their password and the phishing attempt. We run tests randomly, and we run them many, many times through the year, and we follow up with individuals. We have a policy to ensure that every individual, to their best of ability, ensuring that the system is protected. In case of an event where there is a cyber attack and the system is not working, we do have backup online for everything we do. I'm not, again, the expert in this, but my understanding, we can continue doing our work through our computers. Our computers would have contact to our phones, to almost anything. If the system in the health unit is under threat.
Thank you, Mr. Chair, and that's good information to know. So just as a follow-up, do we also have cyber insurance?
Through you, Mr. Chair, this is a very excellent question. The recommendation from Alpha in 2018 or 19, if I remember, it was from the RCMP presentation on cyber insurance. They recommended certain things to improve the system in general. Their comment on the cyber insurance is to keep it confidential. So if we have it, it will be in camera, because it's one of these variables that would attract hackers. If an organization has cyber insurance that people know of, it's like a magnet to hackers. So definitely there will be reports. If we have one, it could be there. Yeah. If I may add, it's related to the first question about what we do, and for emergency communication, we have the radio system. That's an example of things that we can do. We can pick up the phone and call a person and say, there is an emergency, are you aware? But we do it in many different ways. when Len was presenting and she said, exercise went well, I had a smile on my face, not smirk. Because well was a racing car trade for me. Every phone I have went on, every email starts lighting up, my computer starts flashing. So in emergencies, the redundancy is a virtue. And we exercise this, and with cyber security, it's definitely of the highest caliber. We do everything we can to ensure we have the systems.
Well, and thank you for that, but you keep going back to the phone, and if you listen to the presentation from the Stratford mayor, when they had their cyber attack, they lost their computers, they lost their phones, so they didn't have either of them, because everybody's got everything on their phones now, so it could have been part of the problem, so that's my question, and I know you're doing everything you can, I'm just not sure that we could still operate a day-to-day business, because I think your phones are gonna be gone too in this situation, but I think it's something that would be worth looking into more, just to make sure that we could operate, because they attack you when you least expect it, or it would be like in the pandemic or something, when you're busy doing other things is when they attack you, so. I'm just not sure that we would have any communication skills the way we communicate today. So,
Messing for two.
and that was part of his, I don't know if you were in Colin with to hear the presentation, but it was, I learned a lot about our municipality and about looking into our insurance and what we had and what we didn't have. And we would likely be down for a few days. And if it happened in the wintertime, it affects your GPS on your snowplows, it affects everything that we do, so, I would just, does it fall under emergency management? I think it would be a state of emergency if you got attacked, but I'd just like to be sure that we are covered and that we could still operate in time, so.
Dr. Arlen,
I'm not sure what the event that you're referring to, what happened, but if there is an event where every system is down, Rogers down means every payment mechanism is down. And in this case, I don't think any organization is going to be immune.
Well, no, this was just an attack on the city of Stratford. A cyber attack on the city of Stratford. It wasn't everything else down. And they couldn't operate for,
Try to hold them ransom almost.
Yeah.
that's what they do, so.
Yeah, Mr. Chair, that happened to us and me, for example, that same thing, and it was a number of days, and you were held by ransom, and every day it was increasing, so yeah, that was really, really tough.
I don't think any big businesses wouldn't be part of it, could be attacked, any business of the health unit could be attacked.
I think you should just add it to your team of your emergency, just for a discussion. And, you might clarify within yourselves what you need to do or what you don't need to do. But I think it needs to be a discussion, because I do understand, they went through, it was crazy. And then when you're held ransom and your ransom keeps going up every day, or you're gonna lose everything, all your tax base, it was phenomenal.
It's definitely an important subject that is not unique to us. However, being in public health, being related to the healthcare system or public health system related to confidentiality, it's a very core to our preparedness. I'm very confident if there is any intervention that can be done in an organization to protect it, we already have it. I'm gonna invite in the next meeting with the board's permission, our IT manager to share their expertise. I'm not the expert in it, but I trust people will be pleased to hear what we have.
And I don't feel it needs to come back to the board. I think Don's just trying to say, even if your committee has a discussion about it and a quick look into what happened, like to Meaford or the other community, and just to satisfy yourselves that you're covered in any emergency, needs to be discussed once a year, 4 times a year, or maybe it doesn't need to be discussed. It doesn't matter to me if the IT comes to the board, but if everybody wants to hear from IT, that's fine, but.
I think it'd be great. Claire? Oh, sorry.
Thank you,
do
Mr.
want to
Chair.
Back one, and then
Yes, through you,
Is it-
Mr. Chair, just for completion, so our IT manager is part of the emergency management group. And our IT department does have planning and contingency in place, so some of it you're talking about. So though it forms part of this group, they actually sort of have a fairly robust independent plan, and that's partly for some of the security reasons that Dr. Arrow was talking about before. So I don't know whether that particular incident has been considered, but certainly consideration has been given to some of these scenarios.
Okay.
perfect. Sorry, I just wanted to know. Anyone
Thank
who's
you.
jumped in
Yeah, thank you.
Over to you. Yeah.
Thank you, Mr. Chair. Just to suggest that this become an item in camera, since it seems to be something that needs to be discussed. I was on the executive when we did discuss it before, and it is something that should be in camera. So just suggesting that for a future date rather than that we continue to discuss it right now. Thank you.
Thanks so much for that update, and on to the next step presentation, foundational standards, social determinants of health.
So I am also the manager for foundational standards, which includes health equity, effective public health management, and effective public health practice, and population health assessment. But today I'll be presenting a social determinants of health, and I'm sure that you may have heard about it, so it might be a refresher for us. So I'm going to talk about how what are social determinants of health and how they impact our health. When we think about what makes us healthy, we usually think about things like visiting the doctor, we think about exercising and eating well, but there's much more to it. Many factors affect our individual and community health. So social determinants are the non-medical factors which influence or conditions in which we are born, in which we grow, live, work, and age, which significantly influence our health and well-being. And in this, we talk about income, education, employment and employment situations, early childhood experiences, food security and access, housing, social connectedness, access to the health services available, physical environment, disability, indigenous ancestry, gender, race, and immigration. Social determinants of health matter because they're the resources that influence the health outcomes in our individuals, families, and communities. And research has shown us that when we change people's social determinants of health, their health also changes either for the better or for the worse. For example, we know that new immigrants who come into Canada from another country, they become less healthy in their new countries. Families become healthier when they move to better neighborhoods or they are supported to earn more. Individuals become healthier when their social networks improve or when they get less isolated. So the National Collaborative Center for Determinants of Health, they use a tree as an analogy for what social determinants of health are. We know that the health of a tree is determined by several factors: the soil in which it grows, the root systems, the trunk, and that's what affects. So when we look at this, the leaves represent the things that we see, our health outcomes. So maybe our life expectancy, the quality of our lives, our mental, physical health, maternal health, and childcare. But we can't get all those without thinking about what makes the health of the tree. So the soil are the things that are great beyond our reach because they are worldviews, they're cultures, they're the values that in the societies which we live in. The roots are the social determinants of health, and we can do something about the root system. We know that roots, a healthy roots reaches for the nutrients, and the roots are some of those things that I talked about. The trunk are more the individual behaviors that we have, our healthy eating, our exercising, substance use. Okay. So health equity is giving everyone a fair chance to achieve their highest level of health without the disadvantage of social, cultural, or economic factors. It requires us removing the barriers which ensure equal access to resources and opportunities for health. And I'd like to differentiate a little between equality and equity. Equality is when we give everybody the same thing. Equity is when we give people what they need, individual people what they need. And I use this, the different diagrams to show that. If we give everybody the same bike, there are people who will be okay with that. There are people for which that's too small. And there's some people that the bike is just useless to them. But when we give people what they need, we're like giving them the type of bicycle or that they require. And the same with the lower diagram as well. Giving everybody the same ladder just disadvantages some people and gives some people more advantage. Whereas giving those what they need provides equity. So health equity means addressing social determinants of health. And health inequities are the differences that are avoidable, systematic or patterns, unfair or socially produced. And they're avoidable because we can do something about them. They are systemic because they affect particular people or geography, locations. It's unfair because it really comes down to luck of the draws or the lottery of who you're born to or where you're born. And socially produced because the causes are rooted in our societal ills. In terms of intersectionality, it's a way of understanding how these multiple levels of inequality or disadvantage are layered upon themselves and how they compound the health outcomes that we have. So, for example, if you think about a disabled person from a marginalized racial or ethnic background living with low income, they experience not just the individual disadvantages from each of those factors, but those challenges, they interplay, they overlap, they intersect with other factors to make the disadvantage even greater. So an acknowledgement of intersectionality helps us to identify and address social determinants of health as the complex experience that requires multifactorial, multisectorial, and long-term interventions. So when we start to address them, we don't see the results immediately because they're so complex. And it's not just something that one sector can deal with. It means we have to collaborate, we have to continually work on them. So I've talked a little bit about what social determinants of health are, but why are we focusing on it as an organization, especially as a public health organization? Well, the Ontario Public Health Standards, health equity is a foundational standard, and in that standard, it says clearly that in order to operationalize the health equity standard, boards of health shall apply a health equity approach to continuously identify and address systemic and institutional factors affecting health, recognizing how social determinants of health and their reported influence the distribution of health and well-being across communities. And in the second instance, our Grey Bruce Public Health Strategic Direction, we have a whole strategic direction of determinants of health and equity, in which we have said that we will support community partners and the public to connect the importance of determinants of health and outcomes of health. So to bring it home, I will just give a snapshot of the different, where we stand with the different social determinants of health in Grey Bruce. And sometimes I would compare us to Ontario as a general consensus. So in the first place, we know that Grey Bruce has a population of 174,300. And that's the census from 2021. It's a little bit more than that at the moment. We know that we're an aging population. The population group 65 years and older make up over a quarter of our population. And that has significantly increased in the last 5 years as well. The average age for Grey Bruce is 45.5 years, and that's almost 4 years older than the Ontario average. Like I said, we've grown 7.6% in a 5-year span between the last census and the one before that, with the highest growth being seen in the Blue Mountains, Southgate, Saugeen Shores, being the fastest growing municipalities. Income is the most important determinant of health. How much money and resources we have determines a person's health, living conditions, as well as the degree of control they have over life circumstances and stresses. People at the lowest level of income gradient have the poorest health. They experience higher burdens of illness, decreased life expectancy, and a higher rate of mortality. In Grey Bruce, we have 11.5% of our residents living on low income based on the low income measure. Half of our households live on less than 72,500, which is less than the Ontario average of 79,500. There is also and continues to be a pay disparity in our region between what men make and what women make, with women making much less than men. The next determinant of health is education. Education plays a unique role because it influences other social determinants of health, such as income and employment. Higher educational attainments are associated with better health outcomes and longer lifespan through access to better employment, higher income, and more resources. In Grey Bruce, 60% of our residents aged 25 to 64 completed post-secondary education, which is less than the Ontario average. Our 5-year high school graduation rates in Grey Bruce range from 81.5 to 95.8 based on the region or the different school boards. We have 67 elementary schools and 12 secondary schools and a post-secondary institution. We also have a satellite institution as well. Thanks.
Can I just, on your school rates, is that still off the statistics or is that through the pandemic? Because I did hear the 81 to the
Yes.
95.8. Was that through the pandemic or was that before? Where are them numbers from?
So that's after.
After, okay.
So, and you are right, COVID might have played into that as well. So, employment. Employment provides not only income and financial stability, but a sense of identity and daily structure for people. And all these are necessary for our health and mental well-being. A secure job with benefits enables people to meet their basic needs, such as housing, food, and paying their bills. In Britain, 58% of our residents are part of the labor force. That is, they're either working, looking for work, or able to work. 53% of our residents are currently employed, which is close enough to the Ontario average of 55%. And 9% of our residents are unemployed, which is less than Ontario, which has a 12% unemployment rate. Early childhood experiences have significant, immediate, and lasting biological, psychological, and social effects on health. Early childhood is a time of rapid development of the brain and many of the body's biological systems. Positive childhood experiences include safe, stable, and nurturing relationships with caring adults. And this is important for building resilience and overcoming the effects of adversity. In 2018, which is the most current figure that we have, 30% of our local children were vulnerable in one or more of the early developmental instruments domains. The EDI is a tool that we use to determine how well children are growing. 22% of children scored vulnerable in the physical health and well-being domain compared to 16.3% in Ontario generally. Food is one of the basic human needs, and it's an important determinant of health. Food security is when all people at all times have the physical, social, and economic access to sufficient, safe, and nutritious food that meets their dietary requirements. Last year, 2024, a family of 4 in Grey Bruce needed 1,250 per month for groceries. And we have determined at Public Health that this is not affordable for many lower income households. Housing. The relationship between housing and health is quite complex, involving factors such as residential stability, affordability, safety, quality, and neighborhood characteristics. Poor housing conditions can contribute to respiratory issues like asthma, cardiovascular disease, allergies, and much more. Improvements in housing, particularly in the temperature and air quality, can lead to tangible health benefits. In February of last year, 170 households in Grey Bruce were experiencing active homelessness. Currently, about 3,600 people are on both counties' wait list looking for affordable housing. Social connections. People who are more socially connected to their families, friends, and communities tend to be healthier and they live longer. Individuals who have limited access to resources or who live in rural areas, have limited transportation, or experience language barriers may experience some level of social isolation. We know that widows, single-parent families, and residents living alone are particularly at risk of being isolated. And in our region, we have 7% of the Grey Bruce population being widowed compared to 5.5% in Ontario. And if you remember, I said we're an aging population, and that might play into that. 12% of our families are single-parent families, which is better than Ontario, which is 17%. 12% of our residents are currently living alone compared to 10% in Ontario. Access to high-quality healthcare is a social determinant of health as well as a human right. Many groups may face multiple barriers that create access to them accessing healthcare. In 2020, 90% of Grey Bruce residents had access to regular healthcare providers, more in the older age group than the younger. People living on low income are less likely to see a specialist, less likely to fill their prescriptions, or less likely to access dental care, mostly because of cost. Physical environment. The physical environment in which we live, work, play is an important determinant of health. And this includes the natural environment around us, like water, air, soil, our weather, as well as the built environment, such as housing, neighborhood, transportation systems. Our geography, whether rural, remote, or urban, can intersect with other factors and to help shape the status of the population. In Grey Bruce, we have 53% of us living in rural areas compared to 17% in Ontario, and 47% of us live in urban areas compared to 83% in Ontario. Other things that affect our health, disability. Disability is closely intersected with other social determinants of health, as it can influence a person's ability to access employment, income, healthcare, to be able to live independently or maintain their well-being. Individuals with disabilities are at a greater risk of experiencing health disparities compared to those without disability. And if we look, we don't have the figures for our local region, but if we look at Canada as a whole, over a 5-year period, we can see that for all age groups, that's that graph over there, every single age group has increased reports of disability, whether it's over 15 to 25, which has increased from 12 to 20%, to the older age group, which has increased from 38 to 40%. Indigenous populations are significantly and uniquely impacted by social determinants of health. Factors such as colonization, racism, and social exclusion have deeply impacted the health of Indigenous communities, families, and individuals, resulting in health and social inequalities. In Grey Goose County, over 2,000 people reported living identified as Indigenous, and that's up from 1,600 in 2016. Similarly, in Grey County, we had an increase from 2016 to 2021. Gender is something that is intertwined with other social determinants of health as well, because it shapes us and we are shaped by them. It affects how people experience and access healthcare and things like income, education, and employment. We know that in Grey Goose, male residents are more likely to be heavy drinkers. They're more likely to be daily smokers. Female residents, on the other hand, are more likely to have a post-secondary certificate, diploma, or degree compared to their male counterparts. And I said this earlier, that on average, for every $1 a man earns, a woman earns less than 70 cents. Racialized Canadians experience lower income levels, higher rates of employment, and when they are employed, that employment is actually very precarious and with very bad conditions. They have lower occupational status, which affects their physical, mental, and social well-being. The proportion of Grey Goose residents who identified as a member of a visible minority group was just 4% when we compare that to Ontario, which is 34%, and Canada, which is 26%. So we have fewer people who identify as a visible minority group. The areas with the highest visible minority groups in Grey Goose are Southgate, Saugeen Shores, Kincardine, and Owen Sound. Immigration plays a crucial role in supporting economic growth and enhancing social cultural diversity. Despite being initially healthier than the native-born population, immigrants to Canada tend to experience a decline in their health status after arrival. In terms of immigration in the Grey Goose area, prior to 1980, the Blue Mountains had the highest level of immigration. Then we see that between 1980 and the year 2000, Southgate had the highest level of immigration. More recently, 2001 to 2021, the Saugeen Shores have seen the highest level of immigration. So what are we doing about informing people about the social determinants of health and their impact? At Grey Goose Public Health, we are developing a report which we call Health Starts Here, which tells about the social determinants of health and how they affect us, as well as how we're doing in Grey Goose. We've had several articles in the marketplace news papers. We've had social media awareness. We ensure that social determinants of health are considered in our program planning and implementation. And we have started to actively collect data on social determinants of health, because if we don't have the data, we don't have the evidence to show that things are changing. So as a call to action, the Population Health Alliance in 2018 said that once you've studied and considered the far-reaching effects of social determinants of health, you can't not do something. Once you understand how it affects, you can't just let it go. So I just think that it's still 40 years ago, the Ottawa Charter provided us with a tool to help empower individuals and communities. And I really do feel that it's still relevant today in these 5 actions. Thank you.
Excellent. Thanks so much. I had a couple of questions. So, and one of the social determinants that you mentioned was the physical environment in which we live. We broke down by urban and rural outcomes. What is the better or the determinant that leads to better outcomes? Is it better to live in, from the data you're seeing, is it better to live in a rural area versus an urban area?
There are advantages and disadvantages, as you can imagine, for both. Especially in areas that are urbanized, especially when they quickly become urbanized, there are issues with the neighborhoods, with how they relate with the natural environment. However, they usually have better transportation, public transportation. People can reach to healthcare services more quickly. However, in rural areas, because of the dispersed nature, we have some disadvantages, but we also have the advantages of beautiful waters and the physical environment. People in rural areas actually are more socially connected with their neighbors than in urban areas. So there are pros and cons with those.
Yeah, sorry, that speaks to, again, there's not just one, like, one is good, one is bad, right? That speaks to that intersectionality.
That's exactly what I was gonna say. The built environment is a concept. You can apply it to any workplace, to any building, to any street, to any sidewalk. You know, we have, let's say, a sidewalk that's designed very nicely, but if somebody is 70 years old and has pain, cannot do the walk without a seat. If you add one seat in the middle of the block, you would ensure the walkability is available for that individual. This building here, the big windows ensure there's enough light for every worker in the organization. Every office has bigger window to ensure sunlight and good ventilation. That can be applied in urban or rural. It's not the specific rural versus urban.
My second question was just about the immigration determinant, and obviously I'm sure there's huge amounts of intersectionality there as well too, when it comes to employment and incomes and those types of considerations. But have you found that like simply system navigation, health system navigation is a huge factor for those immigrant communities?
For sure, and in Grey Bruce, we're lucky to have the Grey Bruce Local Immigration Partnership, and they're doing good work in trying to integrate people. But definitely just even knowing how to navigate healthcare, how to navigate education for their children is a big deal for a lot of immigrants.
Great. Well, thanks so much for
Thank you.
the presentation. Really appreciate that.
Thank you.
Okay. So we move on to item 11 on our agenda, which is the annual performance evaluation of the board. So this is an exercise that the board takes the self-evaluation process, and maybe I'll send it to Dr. Harris to talk briefly about the process for that.
Yeah, it's definitely that's it. It's just a heads up to the board that you'll be receiving two tools. One of them is completed by the board member, and you will keep for yourself. You destroy it, whatever you want to do with it. It just lays out what the responsibilities are, and if the person is hitting all of them, lays out what rooms of improvement or the training that it just it allows a person to evaluate themselves, and this will stay with the board member. The second one is evaluation of the entire board, how it functions. And it will be anonymous. We will send it to one data analyst here that will remove all the names, and we compose it. It's worth mentioning, this is for 2024, so many people around the board are not from that time, so you wouldn't be able to evaluate the board itself. And in that case, you can just mention, you know, even spelling one line doesn't apply to you, so we know how many people filled it out and fill it. If you have any question now or when you receive the survey, please don't.
Sure.
Thank you, Mr. Chair. I think my only question is, if my understanding is correct, we're going to have another training session. Is that still going to happen?
Yeah. Do you see that we send the evaluation after the training session, or?
And I guess for myself being a new member and not being here in 2024, I wouldn't be able to contribute really to the aspects that you're looking for in the questionnaire. So I guess it doesn't matter really for me as a new member.
Yeah, through you, Mr. Chair, it really is complementary to that. Like if you read the 20 items and number 20 is, are you aware of the Health Protection Promotion Act? And the answer is no. You identified for yourself what you intended. And if you happen to do the orientation before and read it, you would say, yes, I already checked that. So it's literally a self checklist.
Yeah. Good.
That material we sent around to the board. Excellent. Thank you so much, everyone. So now we'll look for a motion that the Board of Health go into closed session at 12:41 to discuss the adoption of in-camera minutes and 3 items related to the adoption of personal matters of an identified individual. And for the Dr. Ara, Jim Rutherford, and also Charlotte being present. Do I have a member for that?
I'll move, Mr. Chair.
Moved by Helen Blair, seconded by Don. All in favor? Perfect. Just stating that we went in camera only to discuss the items that is motion to go into camera. And now with that, I would look for a mover and a second at the Board of Health meeting. Now we adjourned at 1:05. Moved by Jay, seconded by Bev. All in favor? Carried. Meeting's now adjourned.